Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists. So was that a yes or a no to you stop smacking your gum before we start recording?
It is. I will do my best. I'll keep it like I do, like people do, like not like I do. Well, that was weird. Slip it. When people chew, I'll put it right there in my little lip, and it'll be a big bulge, and I'll go sometimes.
Take it out. I don't know. Throw
because
it
I
in the
need
trash.
it. I don't know. I need it.
All right. So.
Episode 80.
Episode what?
2?
82? When are we going to remember what episode we're on? Maybe come to this podcast prepared once?
Let's say episode 83.
Okay. So we were just with each other for like how many days?
Too many to count.
Probably.
No, you know what? I actually had fun hanging out with you guys this time around. It didn't feel like it was too many days.
Well, that's because it wasn't just me by myself.
No comment on that one. No, but I like hanging out with you. But yeah, it was, it was like 3 days, 2 days, 2 solid days and half a day before that. So, man, that was fun though.
We had a good time. We were in Montana, if you didn't catch that on the last episode. And if you haven't gone to Montana, you need to go. Oh my gosh. It was so beautiful. Beautiful. I
loved it.
Highly suggest it. Check it out. But we had a great time at American Eagle and with all of our fellow RDHs and their great minds.
Yeah.
So fun.
I kind of felt in awe of some of the people that we were with. And it gets me every time that we do this kind of stuff because I'm like, we don't deserve to be there.
Such nobodies.
Yeah, that's like, I mean, well, let me back up. Michelle, this is going to hurt to say, but you're actually not stupid when it comes to perio and implants and all that kind of stuff. Like you have your niche. Me, like what do I contribute? Like maybe a business side of thing, maybe restorative, but like I look at it, I'm like, okay, I don't know how many hundreds other hygienists do restorative in my state, so it's like, I don't really feel like it's a novelty.
Yeah, but how many thousands of hygienists do implants and perio?
Yeah, maybe, but I don't know.
Thousands and
I
thousands.
feel like no one takes it to your crazy degree, though, of being so up to date with all the stupid research that you do. Like it's pretty insane, I think. So, but we had a lot of good discussion while we were there, and I was blown away by some of them, and it was fantastic.
It was a great time. It was a good time. You know what is killing me right now with hygienists not being up to date on the research? You remember that lovely little post that you probably typed 2 or 3 times? 6 months, 6 months, 6 months.
Did you see that? Did you see that I actually followed through with that?
I might have saw that once or twice. Do you know that there are still people posting on that?
Really? It's not dead yet?
Yes. It's at like 300 and something comments.
Are they still posting 6 months, 6 months, 6 months?
If I had more time in my life, yes, they are. Yes, they are. So this is my problem, and this is what I want. I want our students to understand, our new grads, and anyone who gives a crap enough to listen to this and take some kind of pearl of wisdom. Not that I have many of them to give, but everyone was saying on there, and it was myself, Anna, and Daniel that kept commenting, this isn't the current updates. This is not the current standard. So anyway, the post was about, can you see a patient for a prophy, was their exact terminology, if they had a bypass or heart attack within the last 6 months. And everyone said, nope, 6 months, 6 months. And then so Daniel, I tagged Daniel, so I totally brought him into this. Sorry, Daniel. And I was like, Daniel, didn't you just post some new guidelines or the current recommendations from AHA and such on another forum? And so he reposted that, which does not state 6 months. It says 6 weeks unless there's, some other issue. And so everyone just kept saying 6 months, 6 months, 6 months, as if that was the correct information. It's probably what we learned once upon a time.
Sure.
But nobody was going back to look to see what that actual standard read or said. And a lot of them did say, maybe, no, you should talk to your cardiologist and get their current recommendations. Well, let's also ask ourselves, do all doctors outside of dentistry understand chronic inflammation of the mouth and how that affects the rest of the body?
I don't know why you put a qualifier there when you said outside of dentistry, because not even inside of dentistry do they understand it. So,
true.
But
True.
you're right. I mean, that's
correct.
The whole point of the post that you guys are making was like, yeah, people don't understand it. So even if they defer, they might not be current on. It might not be even current. Yeah. I mean, we're still doing pre-meds for joint replacement, for crying out loud. And that's been how many years now?
That is not the standard. Yes.
And so,
I just don't understand it. But, at the end of the day, I do think you should yield to a cardiologist in the sense that they know how the procedure went. Mm-hmm. They know the medications they're on. They might know other health issues that they have. Mm-hmm. But then I think you as a dental professional need to also come back at them and say they for oral health standards, this is where they are. Mm. This is their current health. If that were a hangnail that had gangrene on it, would you be okay with us waiting on that? Probably not, but nobody approaches it like that. It's just, they'll be fine. I think it was Chris Potts I was telling this, when we were talking about cancer and chemotherapy and doing oral care. And I was like, what's funny is that if that person had an infected hemorrhoid, I bet that'd be taken care of. But not in the mouth.
Yeah. Yeah.
But not in the mouth, because no one understands inflammation in the mouth or cares or has been just educated to that extent. So, okay, yes, I totally get you should yield to the cardiologist and it's going to depend upon the patient, but you shouldn't just yield to what that receptionist on the phone is like, oh, no, our standard is 6 months. Our standard is pre-med for life. But that's not the standard or the research. So what? And I guess we're just so litigious. Everybody's super concerned that they're going to get in trouble if they don't follow that. But I think it's going to get them in trouble when they don't question it. And now this person has periodontal disease, and now they can't seem to heal from their heart attack or quadruple bypass because they have so much inflammation in their body.
And that was the weekly rant for Michelle. Brought to you by Red Bull.
So what I also want to say is I think it's so funny that you can answer in GIFs. And I said this last time, but I still think it is the best. I literally won't type anything else from here on out. I'm just going to find the best GIF of me ramming my head into a wall. So
that sounds good to me.
Good times.
Keep doing it.
Yeah. So what you got for this episode?
Well,
after my rant,
pretty much nothing. I just literally probably maybe 10 minutes ago just failed my global econ final, so I'm not too happy about that. And
Whoopsie.
I hate multiple choice questions by a lot, and I would much rather have fill in the blank or essay or something like that where I can explain myself better.
So you want to negotiate the answers?
Yeah, absolutely. Let me rationalize the crap out of this answer. No, the thing is,
makes so much sense.
They aren't. Granted, this is a master's program, so that's kind of my bad. But you should have I have an understanding of the principles and the concepts, but I get kind of tripped up on some of the terminology because some of the terminology is new, and it's total fixed cost, marginal costs, variable costs, marginal variable cost, or what? That's probably not even a real term, but it's just all these different things that have one interchangeable part, but they're 4 words long. And I'm I don't have, maybe I need some Ritalin or something, but I don't think I have the patience to dissect each and every one and understand it individual of each other, because it's this one plus this one minus this one divided by this one equals this one. I'm whoa.
That's why I'm not in business.
No, and I should just stop complaining. It's my own fault. I didn't do a good enough job preparing.
You didn't study, did you?
No, I did. I actually studied quite a bit because I took a pretest, and I failed that spectacularly as well. And so
you were like, well, let's go for the gold now.
Well, no, because then I was like, okay, well, the coaching report says I'm deficient in these areas. Let me study those areas really hard that I'm deficient, and then I'll touch up the areas that I did really well in. And so then I did that, and the questions that they asked were just not with the coaching report that I took for my pretest. It was like a whole nother side of the chapter.
Oh.
So I just didn't memorize the whole textbook. Is my fault. So whatever.
Bummer.
Then, yeah, I think that's pretty much it.
Growing a mustache, or did you just forget to shave?
I'm not growing a mustache. I did not shave.
I just saw this like dirty patch under your nose, and it kind of threw me off.
No, because I can't grow any facial hair, really. I mean, without looking like a 12-year-old boy or a 65-year-old woman, whatever. Sorry to all your 65-year-old fans out there. I just alienate everyone as I can.
Yeah.
So, no, I didn't.
Look, Matt's sending me a Snapchat right now.
Yeah, so this interview, by the way, is Matt. I don't know.
Yes, is.
He's an okay guy, I guess, I suppose.
Oh, he has found a traveling beer garden fire truck.
I
all is right in the world.
I don't have the words for that. Yeah, and that's it. That's all I have. It actually was a really good interview. Matt is a wealth of knowledge, and I'm glad that he gave us a second chance
really
after we screwed over his ADHA interview, which is mostly about him. And as a quick sidebar update, of the 2 cells of storage that were in the SD card that got broke, the one that was broken right in half cannot be salvaged at all, they said. And so they're going to try and extract the raw data off of the 1 cell that was left. And I don't know which cell it recorded to. So we're hoping for the best. We're probably lost it all still, but we're hoping for the best. And we'll keep you updated on that. But on one of those 2 cells was Matt's first interview. And it was gold, but it gave a lot more background about him as a person, his ADHA experience, kind of his life, and how and why he got into dentistry, and the path that he's taken since then. But now this interview is going to be more about his work in I guess public health is what you'd really call it. We talked a little bit about fluoride. We talked about some of the controversies that come up because of it, and some of the interesting battles he gets to be involved in, and it sounds like a lot of fun. So hope you guys really enjoy this episode. Hey, Michelle.
Yeah.
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine. Welcome, Matt. Back
Welcome,
to our
Matt.
podcast.
Episode something.
Let's introduce Matt.
So this is Matt Crespin.
You might have known his voice, but that's
you would have known it. Yeah.
I do have a non-last episode, so that's good.
Wait, you do?
Yeah. I've been on your show before.
Oh.
A non-lost episode.
Sorry, it's late. I'm trying to figure out what non-lost meant. But then
I have a lost episode, so people wouldn't have heard that interview.
Yeah.
But they would have heard.
No, just tell Andrew he's pretty.
We had such a good conversation tonight about Michelle
adorable.
teaching people
You're so
things.
Stupid.
Anyway, so it's 10 something tonight, right?
Whatever time zone we're in.
This is
None of us are in our correct
10:40 Mountain Time.
10:40 Mountain Time. Or you're only one time zone.
1
ahead,
hour.
Right? Yeah, and you're
one.
but it's earlier for me.
1 early. You're too late. I'm
So,
late.
yeah, so we are here in Montana.
Yep.
Living the
night
dream.
for you guys. I'm here one more night.
Do you notice that there's moose on the carpet out there?
I did not.
Yeah, so that was interesting.
There's a lot of taxidermy here, though.
There's a lot.
There's a lot of taxidermy.
There's so much.
But we're here for American Eagle. We all came together.
Yep.
Which is great.
Yep.
We figured since Andrew lost the first episode with Matt, we would record again.
Yep.
Actually, this is always the plan.
It actually was always the plan.
If you heard the first one, you would have heard that we were like, Matt, we hope you become VP of ADHA. Wouldn't that be so cool? Tell me who's going against you. I'll punch them in the face, and there will be no other nominations. And then you would have learned that he became VP of ADHA. Congrats.
Yeah. Congrats.
Flat mat adventures would have happened. They have happened, which is super cool. And if you don't know that, just hashtag Adventures of Flat Mat and Facebook.
Yeah.
He's having a lot of fun.
He's having a lot of fun.
He's not in Montana, though.
Having more fun than probably a lot of people in this world.
Yeah.
That looked like a lot of fun.
Yeah.
But Real Matt got to come to Montana with you guys.
Exactly.
That's true.
Flat Mat.
So
We'll throw that in Flat Mat's face, don't you worry.
Adventures of Real Matt.
oh,
We'll hashtag that for the podcast. Adventures of Real Matt is in Missoula for a podcast. So, what are we talking about today?
I don't know. You tell me.
Did anyone
feel
just hear a
like-
cat or a child?
it was downstairs, I'm sure, in the swimming pool. So
I heard cat.
I shared with Michelle my irrational fear this morning. Did you hear that? The thing that there's not very many things that scare me in this world. Like a lot of things are like, okay, if it happens, it happens. And there's nothing to do about it, right? One of the biggest fears I have, someone's going to kidnap my children. I'm so paranoid about that.
I feel like that's a relatively irrational fear.
Maybe. Number two, though, is you saw the water slides downstairs, right? So there's like the regular water
You
slide.
heard this, right?
No, I did not hear this.
And then there's the tubed water slide down there.
Okay.
And my fear is that I will go down one of those tubed water slides, and right before I shoot out the very end, like a steel trap door is going to come down.
No,
And
what you said was they're going to turn the
hold
water
on,
off.
no, the water's going to continue to come down, but they're going to keep sending kids down, and I'm going to be at the bottom as the water's backfilling up.
You're saving all these
And
children,
the weight of
Andrew.
all of these children are going to make it so that I can't get back up. Like I would swim up with the tube, but all these
You would
kids
swim
are
up
going to
with
like
the tube.
push me down, and I'm going to be very aware that I'm drowning, and then I die.
Piled by children. I feel like that's my nightmare.
So it's like claustrophobia and
many
children that I hate,
I think that might be my nightmare.
and drowning. It's like the trifecta.
You added a tornado in there. I'm pretty sure that's
Yeah,
my
I did
nightmare.
not hear this story.
Oh, you missed it. Anyways, it was
It's
good.
for the best. Andrew.
Well, you've heard it now, so
Yeah.
there we go.
Okay, can we just recap who Matt is, since technically we were supposed to have an intro episode prior to this? I don't know if anybody caught that, but we don't have that episode. So, Matt, what do you do? You're a guy genist. Love it. Stealing Andrew's friends one guy genist at a time.
It's gonna be your new little slogan.
So I am the associate director for an organization called Children's Health Alliance of Wisconsin. We look, act, and feel like our own independent nonprofit, but we're really part of Children's Hospital of Wisconsin, which is a standalone health system that's focused on pediatrics, obviously. That's more than just a standalone hospital. We have 30 primary care locations across the city. We do a lot of child welfare, adoptions, foster care for the state.
Wow.
And a huge community services division. And we've actually fall under the government relations division because we do a lot of advocacy. We do a lot of policy work, so we work really closely with our lobbyists and our directors of government relations, both at the federal and the state and local levels. So my role is that I oversee all of our oral health programs. We have 3 different oral health programs, and then I also oversee an early literacy program called Reach Out and Read. And as a whole, we have 7 different health initiatives that we work on. So we work on things like asthma and injury prevention,
Wow.
literacy,
So
oral
very
health.
collaborative, like it should be.
Yeah, a lot of different sort of, we call it under the radar health issues. So we don't work on obesity or physical activity and nutrition because other people are
Diabetes.
working on that stuff. We work on stuff that fewer people are.
I like
kind of
that
working on.
idea, though.
Yeah.
Under the radar.
Yeah.
I like that there's funding for that kind of stuff. You know what I mean? Like, you have to know where to look, obviously, but like that is being addressed and not just, okay, let's focus on these big ones and throw all of our money this way, but like everyone can get the care that they need.
Do you not see that there's any kind of correlation between like obesity and asthma or something like that? Is that not something that could work together, or
Yeah, and
does not really matter because you just need to get the funding so that you can deal with it?
sure. I mean, the reason we haven't chosen to work on some of those bigger issues, I guess, is just because we feel like there's other organizations that are prioritizing that, and we
Right,
feel like there's
okay.
some other initiatives or issues that we want to work on that, you know, people are not addressing, and there's, you know, potential funding, but we have had issues come up where there's funding available, it's an issue that could potentially work for us, but we've chosen not to go that direction, just for different reasons, but we've tried to work on, you know, oral health is actually the initiative that our board first decided to take on. So it's the one we've worked on the longest, and then asthma's the second, and some of the others have just come along as we've grown. But the interesting piece about the way we operate, because we look like our own nonprofit, but we fall within the hospital system, one of the reasons that that's kind of unique is that the hospital developed us, but gave us the autonomy to work independently, because oftentimes we work with and actually receive funding from some of our own hospital's biggest competitors around the state.
Wow.
So when we come to the table, the main focus is on how do we improve the health of kids, not
Right.
on anybody's
For the
bottom line.
greater
Gosh, that's so
good.
awesome.
Everybody kind of checks their badge at the
I'm
door.
moving to Wisconsin.
Seriously, you want to?
Right?
We could have our own little podcast studio and then also help Matt do his stuff.
Right?
Yeah, we got some
And
extra
help Angie
office space.
do.
We could have
got some
oh,
extra
Do we can
you
move
go
in?
with Matt and I'll go with Angie,
Wait, we're splitting up, buddy?
but I don't like children.
Oh, yeah.
Well, Angie's only like an hour away from me, so it's close.
See, look at there. I could commute. Commute
Oh,
in
you're
the middle.
you're willing? No, no. You said you were going to commute. I'm taking you up on that one. I think. Okay, so let me try and get us back on track again for a
Okay.
minute. So one of the things that I
try
remember
hard.
that we were going to talk about this specific episode was fluoride, because it seemed like I had watched a video, and now you were like at a city council meeting or something, and you had to get up. Basically, you were testifying or trying to convince the city council to approve something. So what is that part about?
So one of the projects that we work on, actually a lot of the funding that we manage comes from three different pots. It comes either from federal funding, state funding, or private funding. And one of the projects that we're working on in collaboration with our State Department of Health is on more proactively educating the community on the benefits of community water fluoridation. And more specifically, educating medical and dental providers who oftentimes, I would say a lot of dental providers just sort of take it for granted. Like, we understand fluoride's good, don't really know all the science behind it, and so our role has been to kind of better educate the medical and dental community on the benefits and addressing some of the myths and the science that comes along with that. So what we've done is we've
Fluoride is
developed...
poison, so
Well,
I don't know what you're talking about. I will lower my IQ with every
I know.
toothbrushing.
I mean, if there's any evidence that we're obviously all getting dumber across the country, I mean, I got some crazy stuff that I'd love to sell you. So what we've done is we have created this network where we have our state's divided up into 5 public health regions, and we have a community water fluoridation specialist that we've trained in each of these 5 regions. And in some of the regions they're hygienists, and in some of them they're not. And now actually their role has evolved into more of a workforce educator. So they're educating not just on fluoride, but how can public health departments better use hygienists in improving oral health.
So this is a
beyond
full-time
fluoride.
position, or is this like a...
No, they're part-time
Contract.
contracted positions.
Yeah.
So a lot of times they're hygienists that are working in private practice, and we're contracting with them for, maybe 10, 15 hours a month. And it ebbs and flows based on what's going on in their community. So when they have an issue come up, like what you're probably referring to, we just had a big issue that arose in Green Bay a couple of months ago. one of our roles is to help educate decision makers on the benefits of fluoride and the science behind it. So sort of dispelling those myths. So we've developed a toolkit that we can provide to decision makers to help them understand some of the arguments that are made and why the science doesn't support it. We've brought in some national experts to train the workforce educators and fluoridation specialists on how to provide effective testimony to a city council, how to talk about the issues, how to educate other dental providers and sort of bring support to this. So that's the role that we've played in this around the state. And we've had probably in the last 4 to 5 years, we've had 18 to 20 city councils or town councils or village boards that have taken this issue up, and for the most part we've been pretty successful in keeping communities fluoridated. We've had the 3 largest communities in Wisconsin, Milwaukee, Madison, and Green Bay, all come up in the last 3 to 4 years, and we've been successful in keeping those fluoridated.
Is that pretty regular for a state to have that come up, or is there something going on in your state specifically that keeps making it come up?
Yeah, I think we've maybe had more issues, and I think it comes from 2 places. I think it comes one from I think it's 2011, 2012, where the Health and Human Services decided to change the recommendations on fluoridated water from a range to the 0.7 parts per million. I think that gave opponents of fluoridation some ammo to say, see, we told you, the government said you're getting too much of this, and now we're going to lower it, and that's not really what the decision was based on. I think that gave people some fuel. But in Wisconsin, about 90% of the communities that have a community drinking system fluoridate their water. So we're pretty high rates of fluoridation.
Right.
So I think by default, you're going to have more communities that are going to think about taking it out than states where it's much lower.
Sure.
So I think it was sort of a perfect storm where those 2 things happened. And there's a couple real strong opponents of fluoridation in the state that have sort of brought up this groundswell in communities to activate a network of people to oppose it, and we've had to combat that.
So why are there, I mean, who are these groups and where do they get their funding, like these anti-fluoridation people?
It's a really good question, and I don't know where the funding comes from, but I think it's actually really critical for us as dental providers and supporters of fluoridation to actually go out and see what the opponents are saying, what those that oppose fluoridation are saying. And the Fluoride Action Network is by far the largest, most well-organized opponents of fluoridation in the world. And they're working all over the world, not just in the U.S. And they have very compelling videos. They have very compelling arguments.
Well, crazy has no boundaries.
But unfortunately, it's an issue where you can pick and choose pieces of research and make your argument real strong if you don't tell the whole story. And I hesitate to compare the 2 because there's not a direct correlation, but it's oftentimes the same sort of instilling of fear that people who oppose vaccinations use.
Yeah.
That, that whole science behind that's been completely dispelled. But it's the same sort of instilling of fear that they use to make people weary of using any fluoride-containing product.
So I have a few friends, acquaintances that, and I'm super hippie-ish. I mean, I've said that many times.
Truth.
Yeah, I'm super hippie-ish. I lean more towards less is more in certain instances. Sure. So I have the friends that are super hippie, though, like, don't want to, I mean, none of that. And they're always like, you can't tell me that this is what, blah, blah, blah. I'm like, listen, instead of you saying that this is a problem, if you can find another way to make it better. Because I'm going to tell you right now that if there are Title I schools where kids are having abscesses while they sit in school, and the answer is water fluoridation for them, and you bitch so much that it gets taken out and those kids continue to sit in school in pain, that's on you. And I want you to sit on that for a little bit and get right with that. And if you're still okay with it, then maybe we can have another conversation. But until then, if that's not where your heart is with fluoride, then find another way. But right now, this is what a lot of communities need, and they have to have. And you can't go throw in your opinion. You have the money, you have the time. You sit and brush your kids' teeth at night. That's not happening in a lot of places.
And one of the things that I tell decision makers when I actually sit down and talk with them is that, it's not a debate. There is zero to debate on this issue. The science is super, super clear that it's effective and that it's safe.
Right.
And what the opponents will tell you is, well, the supporters are just going to tell you it's safe and effective, and just because they tell you that doesn't mean it's true. And that's correct, except when you have thousands of studies to support that statement, it's no longer a debate. It's me telling you what the facts are and somebody else trying to distort that. And it's very clear that in communities, even now, that, one of the arguments people use is, well, we get fluoride in our toothpaste. Isn't that enough? And there's studies now that will show
American diet and pH and things like that.
And that's the other argument that's made. And it's actually interesting. I'll tell you an interesting story that came out of the Green Bay thing when I finished this thought, is that the studies show, there's been studies done in Illinois, there's been studies done in Nebraska, Alaska, New York, where on average it's about a 25% reduction in decay rates in communities that fluoridate their water versus cities that don't. So just plain and simple across the board, most people are buying fluoridated toothpaste. You have to kind of go out of your way to not
buy it, right?
But most people are buying it, and so they're using it. But that simple change of having fluoridated water versus not changes the decay rate by 25%.
But significantly.
What's interesting, something that opponents and supporters of fluoridation will agree on, is on the nutrition side. So one of the big arguments that the opponents in Green Bay made was, we need to be focusing our spending of funds not on fluoridating water, but on better school lunches, school breakfasts. And we could totally get on board with that. Let's go together and let's fight for that. But let's get rid of this other argument that shouldn't be an argument and put that aside. And I would agree, let's get school breakfasts that don't have tons of sugar in it in the morning, and lunches that are, bad, that are contributing to obesity and decay and all this other stuff. So I think there's some potential good that could come out of it. But this argument, or this...
Everybody gets super prideful and super on board with they have to deliver their message. They're so dogmatic about it. And you lose sight of what the actual problem is and how do you get to that solution?
Well, and the other thing too is, and you guys know this because you guys participate in Facebook groups and message boards, and I think that the thing that I totally will come clean with is that there are other ways to reduce decay that are not fluoride, and I'm totally on board with that. But I do a lecture on fluoride, and I sort of preface it by saying I'm totally understanding that there's a lot of other products out there that can contribute to the reduction of decay, but I'm going to talk about fluoride, and I'm going to talk about why it's beneficial and address some of the issues that you as clinicians are going to be asked. And I think one of the worst things that we can do as clinicians is be asked a question about something like fluoride that we sort of take for granted a lot of times, that catches us off guard and we don't have a good response for, or we don't know where to send them for the right resources. And unfortunately, opponents of fluoridation are completely killing it on the internet. I mean, they are just destroying us when it comes to search engine optimization.
Yeah, but how do you? Oh, yeah, SEO is a little bit different kind of a thing.
You Google fluoride right now, and the first 8 things that are going to come up are stuff that is totally bogus.
Yeah.
And so if your patient asks you a question And you say, well, you know what, I don't know the answer to that. You should look it up online, because that's what people do. I mean, anytime you get an itch or a scratch or whatever, you Google it. We all do it. And they're going to get stuff that you don't want them to find, because it's going to be things that calls into question. And the vast majority of the public don't have an opinion on fluoride.
Until they read about it.
Correct. So as I think, unfortunately, as clinicians, we have done a really bad job of educating people on why it's good, and we only react to the loud noises when it comes. You know, the squeaky toy is what that's an analogy that people use, is, that it's this noise over here and we have to react to it. And the minute you react to this, there's going to be another argument over here and another argument over there. And we don't educate the public enough on why should you drink tap water that has fluoride in it. And that's sort of goes back to the purpose of this grant that we have, is to really try to educate clinicians on being able to effectively talk about it with their patients. So what we've done is we've created these prescription pads that are like it's not a real prescription, but it looks like a prescription pad that you can write the patient's name on. And it's a prescription to drink fluoridated tap water. And the key point behind it is it has 3 resources that are listed, so that when the patient goes home, they don't have to Google fluoride. They can go to these 3 resources, so that you know that you're giving them direction on how to get really good information. So that was the purpose behind it, is to do that. And so one of the sites is a site we developed, and another site is a site that the American Academy of Pediatrics developed. And the third site is from the CDC, is you're giving them really reputable sources of information so that they can better understand the arguments that they hear, they can find the resources they need, and just really get the straight truth about it.
And you get fluoride from things like green tea.
Yeah, you get fluoride from a lot of things, and
those hippies are drinking green tea. I drink it.
Well, and that's kind of the funny argument that sometimes actually it's hard for you to make as an advocate, but oftentimes city council members will make it, and they'll say, well, you want us to stop fluoridating the water, but there's already fluoride in the water naturally, because fluoride occurs naturally in virtually every drinking water source in the world. So you don't want us to fluoridate at a level that's going to be helpful for your teeth and not cause any harm, but there's still going to be fluoride in the water, so you're still going to drink fluoride. So how do we solve that issue? And there's never really a good response from opponents on that.
Because they don't want to spend more money
into it and strip it.
Yeah, well, I mean, that's the other question is, well, you're adding something to the water. Well, we also add chlorine to the water so that you don't get sick, and that's pretty important too.
Yeah. I mean, really good arguments.
What are some of the
Pretty
biggest arguments so that the opponents have?
So,
penile gland. Is that how you say that? Pineal. How do you say it?
Pineal gland.
Pineal gland.
We've heard people in testimony say it's pineal, but we've heard penile. But one of the things we actually train our spokespersons on is you have to understand how to address the arguments, but the worst thing you can do is to start trying to knock down the arguments one at a time, because you could knock down 10 and there's 10 more that they're going to come up with.
So their argument is like that it calcifies.
Yeah, I mean,
which is something that happens naturally.
And that's an argument that you don't hear often. I would say right now the biggest ones we're hearing are the IQ one, which
maybe it's your American diet that's making your kids stupid.
That's a pretty easy one to debunk. And then, when they talk about the IQ studies, those studies were done in China and Iraq and countries where the natural levels of fluoridation are 15, 20 times higher than what we fluoridate our water here in. But not to mention, they also in those studies admittedly tell you that they didn't control for things like lead and arsenic, which are known neurotoxins.
Right.
So the authors of those studies, the Harvard study, which is oftentimes quoted, actually say in their study that this study should not be used to make decisions on drinking water and fluoridation in the United States because of the way that we fluoridate our water. But the opponents won't tell you that.
Of course not.
So then...
Hold on, do they know that, though?
They know
Do they read the whole
Then why do they say it, then?
I think they know it.
They feel good in their
Drives me
heart when they
crazy.
say that?
And so then the next one you hear is, well, it was published in the Lancet, which is a very reputable journal in Europe. Well, if you look at the studies that were in the Lancet study, it's the same 27 studies that were in the Harvard study. There was no new research done, so it's the same argument.
Right.
But it got published in this journal, and it got published for a reason. But again, should not be used to make those same decisions in the U.S. That's a big one that we hear. You hear this is mass medication. You're medicating us without consent. We hear that. And
because you're not smart enough to do the right things.
Jeez, Michelle.
It's the truth.
Yeah, we should have you stand up in front of city council. That sounds great.
You're not doing the right things.
You can't make that argument in front of the city council. So you have to explain to city councils that, this has been called into question and there's been no court of last resort that has upheld that decision. There's been state Supreme Courts that have said it is not medication without consent. That's not what's happening. So you do at times have to debunk some of the arguments, but if you can focus more on the benefits and the science, that is what's going to sway those decision makers, because oftentimes they're pretty level-headed people that are making these decisions. You can't get into an argument with somebody that has a formed opinion. You're not going to change their mind. So what our roles are as clinicians is we have to influence that 85% of people that don't have an opinion. We have to get to them before they read the Google article or before they hear it from their neighbor or
that makes sense.
Whatever. So I think as a profession we've not done as good of a job of educating people on the benefits.
Because we go after the squeaky toy.
Well, we took it for granted for so long that it does. Like, it makes sense. We know it. So it's hard to... We're going to write an article and be like, yep, we know this still works.
Right.
It's still good.
I don't
the end.
That it forces us to be accountable for things.
Sure.
I don't hate that it's like saying, all right, well, I have this issue, and makes you go back and say, no, I'm still right. Like, because sometimes you get complacent, you get a little sedentary and things. And
sure.
Like the pregnancy thing that we were talking about earlier. Like, this is what I know.
And research evolves. I mean, I think if in 20 years the research changed on this, I mean,
then we change.
We'd have to change. It'd be a big, kind of put your tail between your legs moment. But, I mean, we would change. We would have to change our stance on it because we want what's best for the patient. But you wouldn't necessarily
change unless somebody was causing a fuss. I mean, you might evolve slowly, but you know what I'm saying? Like, there's a lot of things that you have to make some serious waves to make some changes in big professions like dentistry.
Well, the other argument that I also find funny too is it's one of the few things, and maybe vaccinations are probably another example, but where if we were completely successful in preventing disease, we're almost putting ourselves, we're putting the dentistry world out of business in a way from a treatment standpoint. We're still doing prevention, which obviously as hygienists we're really, it's important to us, but you'll hear opponents make arguments that we somehow are benefiting financially from the practice of community water fluoridation. And I mean, I've never gotten my check in the mail, so it's either gotten lost or it's not happening.
We might not even get paid in certain situations as hygienists.
And so that's the argument that I find the most interesting, and it's one that city council members will pick up on instantly. They'll go, I don't understand. I mean, if this is, they're advocating for this, they're treating this disease, they know that this is a way to help prevent it, and they want to prevent it. They're not causing more issues by doing that.
Yeah, for sure.
Absolutely.
So, what should we call this episode? I was thinking SEO, right? Like, let's name it something like, is fluoride good for me? Is fluoride bad for me?
Kids dumb.
Does fluoride make me stupid? Or something like that. And
My phone's telling me to go to bed.
Well,
your phone
we're almost there. We're almost there.
I don't really know how to work this new little thing on my iPhone. Just yelling at me right
It says
now.
go to bed. I have seen
If
that you can set
Matt
that.
and I are hiking the M, which is the legit letter M,
Yeah.
on the top of a mountain tomorrow. Andrew's not joining us. And if we're waking up at 5:50 to be downstairs at 6 a.m., we would get approximately 6 hours and 25 minutes of sleep right now. That's what my phone is telling me.
Actually, you'd get a little bit less than that, because isn't it? Oh no, it's only 11. I thought it was midnight. That's not so bad then. 6 hours isn't bad.
Yeah.
I don't know what to call the episode,
Tomorrow you might not.
but I
like
will
me.
give you the resources for the show notes,
That'd be great.
because it'd be good to put those in.
That would be awesome.
But and that's what we do, is we try to just direct people to those 3 sites. There's the site we developed is called Tap Into Healthy Teeth. Tap, like tap water.
Clever.
And then AAP site is ilikemyteeth.org, which is easy to remember. And then Fluoride Science, I think it's .org. That's actually that's the research one, where they take all of the articles that have been published on fluoridation, and they give you the plain language analysis to say,
that's nice.
you know, the thyroid issue, that's another big one that comes
Ooh,
up.
Oh,
you're
yeah,
right.
yeah.
And they explain why there's not issues on all. They take the studies, and then they explain why the studies are either not applicable, or there's bad methodology, or just a variety of different analyses that are more plain language for you to understand, for people that don't read research or aren't able to understand research. It's a really good site, and I think it was done, I think it was NYU or one of the universities in New York did it, and it's really good. But it's
Nice.
broken down by topic, so you can look up, you know, if you're hearing an argument about IQ or thyroid issues or cancer
Lots of
or
resources there.
osteosarcomas or all these different things, you just pull up that from the drop-down menu, and it gives you all the information.
Very
Nice.
nice. I like that a lot.
That would be a good resource to put in the show notes.
All right. Any last question? Any last comments before we wrap this up?
Should be called The One That Aired with Matt Crespin.
The other one was probably horrible.
I'm going to turn your mic off, I think. Michelle, you're not allowed to talk for the rest of the night.
If it's not called that, I'll be very upset.
It's not gonna be called
It's like
that.
take 2. It gives us a chance to flush
Take
out all the
2.
garbage, and then...
Yeah, the other
that's
one
actually-
was really good,
It
though.
was.
It was really, really
So
good.
is there anything we talked about there that I didn't talk about today?
A lot.
Yeah.
Yeah.
I talked
We
about
did.
all of
We took a
ADHA
different
stuff.
track this
When I
time.
work.
Yeah, we did all that kind of stuff different. Yeah, we did a little ADHA. Okay, that's it. Well, thanks, Matt, for doing this. Appreciate
Yeah.
it.
We're going to go
No
hike
problem.
the M.
All right.
Boom.
Bye.
Bye, y'all.
Bye.
Listeners, I want to tell you a story. A story I found on the web, which makes this Scaling the Web with Andrew.
Okay.
So, this week in Scaling the Web, after Matt ridiculed me about having crap for my Scaling the Web that time, I decided on his episode to do a really non-educational, terrible one, just to spite him, because this is forever going to be out in the ether, and it's going to be always associated with his episode. So, Matt, take that. This is from simplepay.com, and it's a blog, and it's called Top Funny Dentistry Stories Haven't Heard Yet. Most of these, though, I think most of us have heard before. There are 5, hold on. Yeah, there are 5 stories and 1 video about, the video is the David After Dentist that pretty much everyone's seen for forever, since like 2009 or whatever, when it came out. But it's just, I'll read one of them, and then you can choose to read or not read the other ones. Have you ever heard of the website Not Always Right?
No.
Okay. Anyways, well, the first one is off of that website, and it's compiled into this blog. And it says, to set up the scene, imagine a doctor calling into a surgical product hotline while his patient is sitting there, mouth agape, and potentially under anesthesia, but maybe not. The story is told from the hotline agent's perspective. The story. And this must be from a dentist, even though it says doctor, which I know dentists are doctors, but whatever. It says, doctor, the screw is not going in. Which way do I turn it? The agent the hotline says clockwise. The doctor says clockwise from above or below. The agent says, if you're looking at the head of the screw, then clockwise, to the right. What do you mean to the right? Move the wrench to the right? As the screw turns and you're looking at the head, the top part will go to the right. Okay, I think I got it. Good. Righty-tighty, lefty-loosey, says the agent. What was that? The agent says, righty-tighty, lefty-loosey. That's one way to remember. You go to the right to tighten and the left to loosen. Oh, I see. Righty-tighty, lefty-loosey. And then the agent says, great, are you all finished? And the doctor says, yep, you're all done. And then the patient says, thank you, doctor. Isn't that corny? Matt, that's right. That's what you get for talking to me about how crappy my scaling the web was with the mouthwash one.
Oh, my God.
It's going on.
Nothing but quality.
Yep.
Here at AToTH Hygienist.
Yep. And there are four
That was
more.
it?
Matt, there are four more.
Oh, God.
I'm not
That
going to
we're
read them all.
reading on this?
No.
I was going to say.
No, I think Matt's learned his lesson about that. So,
God, Matt, I hope you drink a beer when you're listening to this.
you're going to need like 4 or 5.
Excellent.
It's about that time. Grab your blanket and a glass of wine. It's story time with Michelle.
So, story time with Michelle continues on from the book Communication Skills for the Dental Health Care Provider, Chapter 9, Presenting Treatment Plans, which is something we probably all need to get better about. I don't know. There's probably some really great people out there that can really explain it. I had a student. I think that she one day will be a fantastic patient advocate or treatment planner, treatment plan specialist, or implant coordinator or something like that. Mm-hmm. She just had the ability to break it down and read the room. She knew who was in front of her, which is fantastic.
I like that. I mean, I feel like if you have enough data, there is a way to communicate that data and convince the patient without.
Oh, absolutely.
Because I feel like a lot of them think that's just a sales pitch. And if you can show them evidence-based, they'll be successful. Anyways, go ahead. Continue on.
So why treatment planning matters. Treatment planning is the phase of treatment that most clearly distinguishes patient-centered care from other approaches in healthcare delivery. The traditional model tends to be disease-centered. Providers present the treatment plan most effective in removing the cause or relieving the symptoms of the diagnosed problem. A common alternative to patient-centered care is the business-centered approach. Providers enhance the profitability of their practice by encouraging patients to pursue restorative and cosmetic treatments, particularly if those treatments are paid through insurance. Many practice consultants and resources are available to enhance the productivity of a dental practice. Some of their recommended strategies are transparent attempts to persuade or frighten patients into accepting treatment they do not need or cannot afford, with the result that patients are increasingly suspicious of the motives of dental providers who recommend any treatment. A to the men. Ain't that the truth? The problem of unnecessary treatment recommendations is widespread enough to prompt a movement, minimum intervention dentistry, and in Great Britain, an investigation by the Committee of Inquiry into the unnecessary dental treatment. Isn't that crazy? There's enough of that. It's so profitability driven. So practices must, of course, remain financially healthy if they are to continue providing care. Given this obligation, providers must rely on their professionalism and ethical commitments to present options and plan treatments that meet their financial obligations, the patient's clinical needs, and the terms of the patient-provider relationship. Patient-centered care first acknowledges that not all appointments require treatment planning. Patients exhibiting good oral health and good health habits have no need of treatment beyond their regular examinations. Aesthetic treatment options can be presented, but any attempt to pressure patients unreceptive to aesthetic procedures threatens to undermine the relationship. Patients do not like being told by a professional that their appearance is inferior. With patients who require no treatment or who require additional diagnostic tests or consults with a specialist, providers should implement communication strategies for ending an appointment provided in this last section of this chapter. So, I got so much to say, but I'm going to behave myself because I'm not drinking wine, and I do better when I don't drink wine. So,
do you though?
looking at, I mean, don't I? I mean, it's a fine
I would
filter
say yes.
that's
you're right.
between brain to mouth, but it exists and it's dissolved quickly upon wine drinking. Okay, so the chapter checklist. So when we are looking at things, we want to categorize procedures. So prescribed and discretionary. Acknowledge the patient's reasons for declining treatment. First, present the do nothing option, followed by the prognosis. Use prescribed instead of mandatory and discretionary instead of elective. Clarify whether treatment options are restorative or preventative. I know that some doctors out there have a problem with that, even though it can go either way these days. Describe every treatment option in terms of the presence of the problem and the strength of your recommendation. Provide moderate detail in the diagnosis. Provide a rationale for the restorative treatment options and recommendation. Consider 3 factors in determining recommendations: patient-related factors, tooth-related factors, and treatment-related factors. Present decision factors to the patient at a level he or she can comprehend. Involve the entire dental team, including specialists, in the discussion. And discuss risk of the patient's problematic behaviors and refer the patient to a specialist. Oh, look at there. Refer to a specialist. So rare these days. Okay, so when we discuss a treatment plan, use the term discussing rather than presenting a treatment plan. Oh, I like that. We're going to discuss your treatment plan versus present your treatment plan. I think that sounds better.
I think it does too.
Present options and recommendations. So focus on the chief complaint or diagnosis. Mention at least 2 options. Indicate which option you recommend. And then you want to outline option details. So tell the patient whether the options are prescribed or discretionary. Describe details of the treatment options in adequate detail. Compare and contrast the options in terms important to the patient. In other words, pain relief, function, aesthetics, and cost. And then you want to estimate the amount of time and money each option requires. Estimate how long the treatment will take and how long the results will last, which is where I think we screw up with implants a lot. Mention responsibilities as the provider and the responsibilities of the patient for each option, and summarize the expected outcomes, offering ranges and using provisional language.
Can I say something about that?
Mm-hmm.
All of that?
Sure.
Or are you going to keep going along the same thread, or are you going to change topics?
What do you have to say?
Okay, so one of the things that I've noticed a lot is we have in our template notes this thing called PARQ. Have you ever seen that?
Okay. PARQU?
No, just Q at the end.
Oh, okay.
So it's
no.
procedure, alternative, risks, and then questions. And so the idea, it's the same exactly what you're saying is, okay, hey, this is what the procedure is. Here are at least what they say, 2 alternatives, right? Mm-hmm. And then here are the risks, or what they were saying is about, hey, this is how long it's going to last, or what you can expect to last. And if they have any questions. And lately I've been kind of using a lot of, for the hygiene side of things, the alternatives a lot, and the risks a lot, or the projections a lot for how long I think whatever we're going to do is going to last. And changing the terms from prevention cleanings to therapy cleanings is what I've just changed everything to. I don't say prophylaxis. I don't say deep cleaning. I don't say any of that stuff anymore. But I feel like using the PARQ, or what you're talking about, I think is pretty successful in convincing a patient to get the right treatment needs.
That sounds right. I mean, it sounds better than just throwing a piece of paper at somebody and it's like, you need these. A crown's the best way to do it, which is what happens a lot. And I think that it shouldn't be done at the tail end of a hygiene appointment when I'm having to freak out about how late I'm running, and now I got to give a treatment plan, or the assistant wants to stay in the room and give the treatment plan, and I'm trying to clean up around them. That's just not cool. So there should be a room. Somebody was trying to call it something, or they were trying to re-term the consultation room, and I was like, I didn't like where they were going with it. I can't remember though. Okay, so I'm going to skip over to motivational interviewing because I think I'm really into motivational interviewing right now and trying to learn it as best as I can. So when we're doing motivational interviewing, we want to express empathy. So find an appropriate balance between empathy for the patient and the clinical detachment. Communicate empathy and active listening through both nonverbal and verbal channels, and avoid temptation to direct or advise the patient. So I think that's hard sometimes for us. And they always want to ask, like, what would you do kind of thing. Mm-hmm. You want to support self-efficacy, so enhance self-efficacy by providing multiple treatment options, explore ambivalence rather than simply telling the patient that he or she is capable of carrying out behavioral change, accept resistance from the patient as normal and rational, avoid labeling the patient unless the patient embraces the label. That's like, what kind of label?
You're a weirdo.
I should read that section.
Is that a good label for him?
A PETA patient.
Oh, yeah.
When encountering resistance change strategies, acknowledge that the patient has intellectual or emotional reactions to the change, and you want to explore resistance or propose other treatment options. You also want to develop discrepancy. So identify the patient's oral health goals and note conflicts between goals and behaviors. Clarify and emphasize the relationship between oral health practices and oral health outcomes. Increase cognitive dissonance. Avoid imposing your own beliefs on the patient. And ask open-ended questions. Supply affirmations. Reflect the patient's words and thoughts and summarize what the patient says. So I think that's really important. And motivational interviewing is definitely something that I've been trying to implement within the outreach program I'm at. And I think it does help. You know, what works for you? Tell me, what do you like about the products that you're using that clean your teeth now? Like that kind of stuff. Like, I think it really makes a difference. And nobody asks that. So when you come at them that way, it's almost like, oh, well, you're not screaming at me that I'm not flossing. Okay. It's very fun. I think I'm enjoying that part. So there is that story time with Michelle.
I love it.
What else?
That was a wonderful one.
And we have RDH Under One Roof coming up.
Yes, we do.
So hopefully everybody will be there. Everybody that is there will come find us. Andrew's got a lot of stuff he's going to be doing on the floor.
Lots and lots. Let's take lots of pictures. Let's record some intros or your own episode if you want.
Yep. And if what he's talking about, the intro, is that we want someone to come over and record the first part of our intro, Welcome to Your Unofficial Dental Hygiene Podcast. And so you could be that person, have multiple of you, and you can have your own little intro on a podcast. So it'll be so much fun.
It'll be a lot of fun. I hope to see you guys there. And bring your friends, because RDH Under One Roof is by far one of our favorite conferences to go to. It is. You're going to get a lot of good CE out of it, but you're also going to just have a lot of fun with a lot of people, a lot of events, a lot of networking. It's Chicago. I love Chicago.
Yeah, Chicago's great. We haven't been there I haven't been there in the summer, so that should be interesting.
It'll be fine.
No, I'm excited
it's
to go.
Better than
Usually
the winter.
It's like super cold. Yeah, it's normally like super cold, and it's not fun.
Yeah.
Well, it's fun, but it's still cold.
Yeah.
So I hope everyone has a great week, though, and we look forward to seeing you out there.
All right. Bye, everyone.
Bye, y'all.
Okay, so here's the thing. Like, Michelle probably doesn't feel the same way, but I feel like a lot of the time, this is exactly how Michelle is. She gives people.
This is not how you are.
She gives people
it's exactly how you are.
that she cares about the most crap.
Yes. Yes.
So if she's giving you crap, I mean, she likes you.
Yeah.